everybody. I'm Susan Clinton, and I'm here with my co-hosts Joletta Belton and Carolyn Van Dicken. And this is the Genius PT Project. Welcome to project number 7, entitled, Do I Silence My Patient's Distress? This particular project this quarter is going to be with invited lecturer Dr. Bronwyn Thompson from New Zealand. And Carolyn is going to lead us off in an introductory discussion about this very topic.
Awesome. Well, thank you, Susan. I am really just so excited to have Joletta on this particular talk. I mean, I'm excited always to have Joletta on our conversations, but Joletta is really going to hold us accountable from a patient perspective around what we as clinicians think we sometimes do or sometimes don't. Sometimes we believe that what we're doing actually is not silencing our patient's distress, but often it may be. And so Joletta, just really looking forward to having you take that perspective and really hold us as clinicians accountable to this process. So here we go, let's dive in. All right, so we're talking about, I mean, for most of our audience, many of us are physiotherapists, and we really want to start to look at, again, what we have examined on many different projects of the Genius PT Project. And it's the concept of why do we need to change our practice? Like, what is driving this? What is leading us towards change? And this particular statistic shows that actually the disability adjusted life years for MSK conditions is significantly on the rise. So between 2006 and 2016, 62% increase in the amount of disability that people are struggling with regards to MSK pain and conditions. Obviously, that's increasing our healthcare costs, and our healthcare costs are already burgeoning and out of control in almost every society across the world. And again, this needs to be near and dear to our heart, because as physical therapists, as physiotherapists, that's primarily what we do in certainly private practice, is we treat a lot of MSK conditions. So again, this is a problem that is very real and needs to be addressed. So my introduction really to a biopsychosocial framework was in 2008 from a wonderful physiotherapist by the name of Debbie Patterson. She's a Canadian, very involved in starting the pain science division here in Canada. And her first class that I took on women in pain, and my introduction to really understanding persistent pain from a very different perspective than what I had been trained, led me really to travel to Nottingham, England in 2010 and participate in David Butler and Lorimer Mosley's first neurodynamic and neuromatrix conference there. And that's where I met Sandra Hilton. And Sandy and I really left that conference from a pelvic health perspective, wondering how we were going to integrate some of the great concepts that we had learned on the conference and sort of through our journey over the last couple of years, really just understanding pain science and pain biology and a more integrated biopsychosocial approach. And so this is a framework actually that came out of those early days when we started to look at the integration of a biopsychosocial framework. And what I'd like to highlight here is even 10 years ago, what we looked at that point was the importance of starting in a framework that looked at patients and their distress, really listening. So the picture on the left is what we typically have been trained to do as physiotherapists and are currently being trained to do. And that is sort of get through the history fairly quickly and get your hands on the patients and your patient and start to palpate their tissues and move them in different directions and figure out what's going on in the tissues. And so I've kind of circled this left-hand column of this framework saying that this is kind of, even a decade later, this is still where we're stuck. We really are stuck in looking at tissue dysfunction. And I know, Joletta, you and I had a conversation a little bit ago, and I don't love that term tissue dysfunction anymore either, although 10 years ago, that's certainly what we used. You know, I certainly would prefer to use the terminology around tissue involvement, for example, but dysfunction has such a problematic component to it, particularly in persistent pain, doesn't it? Any comments on that?
Yeah, and one of the things that we were chatting about in that exchange is the the way that we've been transitioning, and it's kind of cool to see this and see your evolution over time in terms of your thinking in your language too, specifically, and moving away from these kind of pathophysiological terms and mechanisms where our narratives about the person that has pain tend to be very clinician-centered or pathology-centered or tissue-centered rather than person-centered. And I know we're all trying to move to what would be considered person-centered care or patient-centered care. And I don't think we have a very good idea of what that actually looks like, though. And I know we've talked about it before in terms of language and referenced other papers about language where people with pain are labeled with so many different types of disorders and dysfunctions and things that are out of alignment, and everything is very negative. And depending on the clinician that they're seeing and the lens that they're seeing that person through, they can just get more and more and more of those labels. Their movement is dysfunctional. Their joint is dysfunctional. Their thoughts are dysfunctional. When really, that might not be the case. They might change. They might be adaptive for a time. They might not be helping that person so much, but they might be the best that that person can do or that person's human organism can do at the time. So I think looking through these changes have happened in the tissues that might be contributing to this pain experience is a better way of framing it rather than saying that it's dysfunctional, because when we start to own all of that language, and it becomes a lot when you think of yourself as disordered and dysfunctional, and all of these different labels that we get assigned. It's really hard to move forward thinking that that's what you are, so and I think that our language is moving and shifting towards more patient-centeredness and less focused on the medical narrative or the biomedical kind of perspective of looking at the tissues first rather than the person first.
So maybe changing the word from tissue dysfunction to tissue changes?
Yeah, or tissue involvement, like Carolyn
Or
said.
tissue involvement, yeah, just something that is at the level of the tissue, but doesn't necessarily mean it's a good or a bad thing. I mean, people will look at a scar as a dysfunction, but a scar is a normal adaptive change for healing. So, and I think, I'm kind of like, just trying to bring it into some sort of a framework that the novice person can kind of wrap their head around, because it is hard to change a word when you're used to using it. But if you start to think about what that meaning of that word is, that helps. Thank you.
I think that's a great point, Susan. And if you think about sort of scar dysfunction, if you will, for example, the scar is not dysfunctional at all. The scar was a very functional component of the body healing itself. And I think we tend to forget that the body is incredibly capable of taking care of itself and healing itself in the best way that it possibly can. Now, maybe that scar healed with too much tension, right? Maybe the scar itself just was a bit tight and needs to be mobilized. Well, that's easy enough, but it's not that it's dysfunctional. It's maybe just a bit tight. And that does that feel different from a patient perspective, Yoletta, when that's the discussion?
Yeah, I think so, because to me that leaves much more room for change, for the ability for future change and future adaptations that are going to be helpful and beneficial. Right. And I think that the more that we can do that, like move towards that adaptability language and that, bioplasticity type language, the more accurate it actually is, and that the more helpful it might be for the person too, because then that builds you up. Like, yes, I am tight, or I feel this stiffness, or I feel like this is happening, and that can change if I do X, Y, and Z. And I think that's much more empowering too. Because like you said, our bodies are amazingly adaptable and figure stuff out without us interfering. They can, a lot of times we mess it up through our own interference sometimes. And the more that we can think in those terms and speak in those terms and conversate in those terms, I think the more rehabilitative that actually is. Because then it's focusing on what you can do, on the function. And everyone that comes in is functional to some extent,
Mm-hmm.
they got there, you know, so they
Not
got there. So
right.
they are functioning.
Yeah.
And I think the more that we can focus on those sorts of things, the better. And then it makes it more about the person too, and less about their tissues, you know, because it's the tissues are just one part, and something that might feel restricted or tense or tight, that might be because of fear of movement, because they think that they're dysfunctional or disordered, or all of these other contextual things that might be inhibiting their movement in some way or changing their movement in some way because of pain or because of beliefs surrounding that pain in that experience. So that makes things, is it really the tissues that are making this feel this way or behave this way, or is it more contextual factors that might be contributing to that? It's like touching your toes, you know, where some of that can just be fear of falling over for people. Mm-hmm. So if that fear is removed by some type of support, they can all of a sudden touch their toes, like those types, like, but mm-hmm. It's not tight hamstrings, which we might attribute it to, and say that that's dysfunctional when really, like, we're just so much more fascinating and complex. And so I think making it more about the person who is experiencing these things, these ways that they're feeling their body, the ways that they're moving their body, the ways that they're existing in the world, the more it can help them to come to a better story about their pain and their experience and see future possibilities in a different way, where they might not have seen possibilities before, or they might have seen that they're very limited. I think it just opens things up a little bit more.
Mm-hmm. So if we go
it
back,
isn't so distressing.
Right, absolutely.
You know?
We don't want to silence their distress, but we don't want to create their distress either.
Right.
It goes both ways. So if we take that scar example that Susan gave us, which is excellent, you know, it may be that the tissues are involved in that they're tight. It may be that they're just really fearful, as you say, and they don't want to touch it. And you know, when it's tender, they just avoid it completely. And fear is sort of more that component that needs to be addressed, really, right?
Yeah.
But you don't know that until you really start listening to your patient's story and to the narrative, because you can just assess the scar and say, yes, it's tight. Yes, it's dysfunctional, if that's the word you choose to use, although we're encouraging you to think about different wording. It's the bigger story behind the scar and what it represents to them. And sometimes it's, you know, what does it represent to them? Maybe it's a scar because they had an emergency C-section and they lost the baby. Mm-hmm. And that's a different story again. That's a different context, right? And so when it comes to really listening to your patient's narrative, first of all, it's asking open-ended questions. It's spending a lot more time listening and less doing than we've been taught typically as physiotherapists. It's using distress questionnaires, and Bronwyn Thompson is certainly the clinician that I have learned more about distress questionnaires from than I think any single clinician, which is why I'm so thrilled to have her you know, sort of be our guest lecturer on this project. And so, you know, do we assess their distress more specifically, those yellow flags, and do we try and, help our patients identify what might be contributing to their sensitivity, for example? Or does sensitivity just become another label? And then we run into trouble as well, right?
And I think you touched upon something so important in terms of like tapping into what that distress is. And sometimes that can happen through simple questions too, like what worries you the most? Mm. What is your understanding of why this hurts when you do this? Mm-hmm. You know, why do you think it hurts when you do this? And then that can start tapping into some of that distress that might not come out in another way. I know even for me, it was never something that was explicit, like examining the things that might be distressing about my experience. And so much went into that, you know, like my career being on the line, my financial security being on the line, my identity being completely upended by not being able to do the things that I did that made me feel like myself. And that's the case for so many people living with pain. They're not able to do the things that make them feel like themselves, either because of physical limitations or because of worry about making things worse, or fear that, like, if they've been hearing things like it's bone on bone, that, I mean, imagine trying to move when you think every time you move, you're just grinding away your bones. Like, that's a terrifying way to move through the world. So understanding what is really worrying people and what might be adding to that distress can only come through those kind of gentle questions and those conversations, and just like you said, listening, being a person to a person, like you would with any friend or loved one that might be experiencing something stressful or difficult.
Just human to human, listening to the story, right? And I think as clinicians, if we can sort of move away from we have to fix everything versus we just have to hold space for their story and help them to move towards what needs to change in their life in order for them to gain back the function or things that are important to them.
And hopefully that's a relief for clinicians out there too. You don't have to fix all of the things, and you shouldn't be expected to be able to fix all of the things.
If you're listening to this, I just put the next slide up, and I put a book up called The End of Physiotherapy by David Nichols, who is a PhD physiotherapist from Auckland, New Zealand. And he does a really lovely lecture, if you want to listen to him speak on this topic on YouTube. And he really talks about how we need to, as a profession, move away from body as machine type of framework that we have had, which is kind of why I've put this over the tissue dysfunction piece. It's not that tissues aren't important, and we need to continue to assess what's happening in the tissue. It's a relevant piece of the story, but it's only a piece of the story in persistent pain. And all of the other components that contribute to their story are probably more important. And we are going to help our patients find those pieces better when we are better at listening, when we're better at really understanding how to not silence their distress, but actually be comfortable to sit with their distress.
I would have to say, I think that's just as important when it's not persistent pain. Maybe at the first, they come in, they have back pain. They've never sought treatment for it before. And really, I think it's important to hear their distress also there and really find that out, even though, okay, well, they just got into, it's the first time, and people tend to kind of run over their story with we just need to get you moving and doing this. And it's like just spending a little bit of time finding out what happened. What do you think happened? Has this ever happened before? And then all of a sudden it wasn't the first time, this happened 10 years ago. It was horrible, and so their distress is very apparent. Or it happened like Joletta was saying, it happened in the context of something, so, and I think just your words, Carolyn, if you're going to do the biopsychosocial approach, you need to do the biopsychosocial approach. You need to live there. And I think that's, kind of the, that's where the struggle I think some clinicians have is they want to be in one world and then they want to be in the other world, and they want to be in one world and the other world, and they haven't have the emotional impetus to change to the other world yet.
I think that's so important. Sorry, Carolyn.
Oh, you go ahead, Joletta.
About that, being a first time thing or being acute or whatever, the distress is important there too. That person could believe because of this that they're not going to be able to do the things that make them feel like themselves, that if they're a recreational athlete, that they're not going to be able to, play in the beer softball league or soccer or go to the gym if that's something they enjoy doing, or that they're not going to be able to work. There could be all of these fears with a first incident of whatever type of pain. And then if that comes out, some of those worries can be alleviated, through acknowledgement. I can understand why that is so worrisome for you. That makes sense as a human that, that these worries would take place, and then providing some, reassurance, that acknowledgement and validation. This is a very human thing to be feeling and experiencing. And these are some things that we can talk about to show you that that's not going to be your future, But if we don't do that, if, like you said, you skip right to let's get you moving again, and you skip over that whole piece, there's a lot of cognitive dissonance there for that person in pain. No, I'm falling apart. What do you mean get moving again? you
Mhm.
know?
And you know, it's interesting. I don't know if either of you looked at Hashmi's research in 2013, but that's exactly what they showed is in acute pain, they did fMRI studies. And depending on the area of the brain that was the most dominant in acute pain, whether it was the limbic system, the emotional response, the distress response, or the sensory motor system, where it was more of a sensory motor sort of control problem, they could predict with 100% accuracy who would go on to have persistent pain. If your acute pain was very limbically driven, a lot of sort of firing in the limbic system, then you were much more likely to have persistent pain. And again, they were able to correlate that with using distress questionnaires like the pain catastrophizing scale, for example, and the fear avoidance scale. And that would actually predict what they saw in fMRI. So we should be using this in acute pain as well, right? Because their story or their context, if we don't really listen to it and start to address it, can be the thing that creates persistence.
Yeah.
And
I mean,
often,
every persistent pain, experience starts
yeah,
somewhere.
yeah.
It doesn't start persistent.
Oh,
It all starts somewhere.
yeah, yeah. So up on the screen now is a model that Bronwyn Thompson has postulated and published certainly on her weblog in 2018, May 27. And I always like this model because it helps us, I think, as clinicians, as physiotherapists, and I think it probably helps people in pain as well, to understand that pain is complex and that the experience of pain has very little or almost nothing to do with tissue nociception, tissue danger messages, where that's where we tend to spend almost our entire interactions with our patients looking for those nociceptive drivers. And if you look at this model, behavior has a lot to do with our thoughts and beliefs, may have more even than nociception, but look at emotions and look at context. If you silence your patient's distress, if you don't really dig into what are they feeling and how are they experiencing this and what's the context, what's the story, then the likelihood of you helping them resolve for themselves this painful episode is going to be significantly reduced. So that really leads us to talk about a lovely meta-analysis that just came out in 2020 by Rika Holopainen. I hope I'm doing her name justice. I always wonder when I say her name. But this was a meta-analysis that looked specifically at, or systematic review, sorry, that looked specifically at physiotherapists' experiences of learning and implementing a biopsychosocial approach to treating musculoskeletal pain. And she really comes up with 4 themes specifically that came out of the research. First of all, that when therapists take or learn a biopsychosocial approach, it really changes their practice and their understanding of pain. So first of all, there's this deep change that needs to happen. And there's a real professional benefit. So we'll talk about a few of these things in detail. Where I would like to really focus the next maybe 15 or 20 minutes yet of our talk is on the clinical challenges of doing this, because unless we really take this broader based approach, we are likely to get stuck in that tissue dysfunction, sort of biomechanical column that we saw and not really take the whole person into consideration in their story. And then what are the requirements really to learn this approach? So let's dig in a little bit here for just a moment. What physiotherapists reported in this systematic review is that they understood the importance of needing a biopsychosocial framework to treat persistent pain. That person-centered care was really the hallmark of taking this type of approach with patients, that again, it was their story, their journey. I always say, I'm the harbor captain that comes onto their ship for just a very short period of time to help them negotiate difficult waters, but I'm not the captain of their ship. I'm not the pilot of their ship. I'm just helping them through some difficult waters. And I'm going to leave again. I'm going to get off their ship, but it's their ship to drive. Do you have any comments on maybe another way you might describe that, Joletta?
I think I think that's such a wonderful way of conceptualizing it, because I think we forget that sometimes, that these are people who are living with pain or with themselves,
Mm-hmm.
24 hours a day, 7 days a week, 365 days a year. And within that time, the time that is spent in the clinic or with healthcare professionals is very small, relatively speaking. That time that they're spent seeking care is a small percentage of their overall lives. So I think it's really important to center it on the patient. And then to do that, and what that means, especially through this biopsychosocial framework, is that kind of being human to a human, and making sure that our language and narratives aren't so clinical centered or medical centered or science centered, that it's person centered, because it's this person's life and story that we're trying to make sense of and help move forward in a direction that's going to be beneficial for them. And that might not be the ideal, you might have the best treatment plan in the world, that if all of these things were done, you're sure this person's going to get out of pain, but that might not be relevant to that person or be aligned with their goals and values and the life and the context that they live within. And that's okay. It's about coming to something that's going to work for that person, that's going to make sense biologically, but also biographically for the life that they live and the person who they are.
Another experience of physiotherapists learning this approach felt that they really developed better therapeutic alliance with their patients. Susan, any comment? You and I are both dinosaurs to some extent. We've been around this game for a long time. And so we have seen this transition in our own practices, really, of being very biomechanistic and kind of top down and clinician driven, to this alliance that we've created through this system. Any comments on that?
Yeah, it's just, first of all, I have to say that when I started learning about biopsychosocial, everybody was calling it pain science and pain speak and things like that. And I remember sitting at a place with Sandy Hilton,
Hmm.
and we were talking to one of the guys that was there, that was doing a communication application thing for a particular conference we were going to. And I knew him from Pittsburgh, and we were just visiting, like you do at conferences and stuff. And he said, so how hard is it to make the switch over to talking to your patients differently about pain? And at the same time, she said it was the easiest thing in the world. And I said, it's been the hardest thing I've ever learned, at the same exact time, which just shows that, everybody's experience. Gilletta's brought this up a lot. The culture, the context, the experience of who we are and what we're doing, and how hard it is to even though it's the right thing to do, how hard it is to make those changes and stuff like that. The struggle can be real, but it's so important, because on the flip side of it, the therapeutic alliance and really unburdening yourself, and just working with the client instead of trying to, it comes from, just comes from, like, we need to fix them, I think, which was the very beginning of the stuff you talked about, and really beginning to, what I need to do is just hang out side by side with them. So your thing of the harbor captain, taking ships through harbors and through rivers and different ports of call, I kind of use the thing like the travel agent.
Mm.
I can give, because I like the idea of giving them options
Right.
as well. Like, these are all the things you like, these are all the things you want to, here's all the things that you can do, here's all the things here's the directions you can take, and I'll kind of help you with all of those. But they're still doing it, because Gilletta brings home a great point. And it's really important for people to hear, and I just want to highlight it. The time they're spending with you, and they spend more with PTs than most other people, but the time they're spending with you is a blink of the eye in a week.
Yeah.
They really are not hanging out with you all the time. they're really not. In your practice, you may feel like they are, but they're not. They're really spending a lot of time away. And so this is just really a nice way to, it's not a nice way, it's an effective way to help them gain the self-efficacy that they can change.
I love that you and Sandy had a very different response,
Oh,
and
at the same time.
yeah, so my memory of that is, it was the best of times, It was the
It
worst.
was the worst.
Right?
And it was just, perspective at the moment. She was,
Mhm. Yeah. Yeah.
it was good because it was okay to say that I was struggling with it
Yeah.
because I wasn't going to change until I could
Acknowledge that.
attach some emotion to it and really need an impetus to change. And she had already had that moment and was moving forward through it. And we were at just different stages, but
Well,
we had different experiences.
Okay.
I love that you brought all of that up too, and that you talked about the you as a human being and as a clinician are also bringing all of your thoughts and beliefs and contexts and
Mm-hmm.
emotions. That same slide from Bronnie about pain, it's not just for patients, it's for
Mm-hmm.
all of us as humans, and all of those ways that those things interact. And it's two people coming together with all their own circles,
Yeah.
that are having this conversation and trying to make sense of things and move forward.
Yeah, looking at that shared
Yeah.
shared communication.
Yeah.
Mm-hmm.
The other benefit that physiotherapists perceive is that it really gives them a much more broad-based skill base to deal with patients in pain. And so that's a really interesting sort of piece. The professional benefits are it increases your confidence when you really adopt this framework. It really gives you new skills, makes you more confident to see this patient population. It is a more effective way of moving through the world in this patient population because, again, it's patient-centered, it's person-centered, and it really is about helping them to increase their activities within their valued space. And it makes our job actually more interesting and more fun. It takes the pressure off us. And so I think those are really important components. What I would like to maybe spend a couple of moments on yet is the clinical challenges because they're real, right? This is a very real challenge. I've read research that shows it takes about 17 years to to translate research into practice. 17 years. So I figure that in the next year or two, we've spent the 17 years as far as the biopsychosocial framework is concerned. I feel like we're at that turning point, and we talked earlier about just the whole world being in a place of distress at this point and anxiety. And I think maybe the pandemic and some of the other social sort of constructs that we live in may be the impetus for all of us to say we have to be more compassionate as clinicians and have to be more open-minded to take a broader perspective because there's not a simple solution.
Mm-hmm.
Right? So the first problem is that we are uncomfortable with psychosocial factors. As physical therapists who spent time training in the physical body as a machine, as David Nichols says, we are not trained in the psychosocial components. So that's a real challenge. Many of us feel that this takes us outside our scope of practice. Although I'm going to challenge to say if you treat pain and you look at the definition of pain, it's sensory and emotional, then don't treat pain. If you think this is not in your scope of practice, then make a choice not to treat persistent pain because it is sensory and emotional. And I know in Canada, there is not a psychologist and a social worker for every patient in pain. And for every person in pain with a social worker, there's not a physiotherapist right there working along with them. So we all have to broaden our scope and broaden our perspective. And then there's a lot of resistance. We like familiarity, which is why there's so much unrest right now because there is a lack of familiarity. There's a lack of predictability of how the world looks and is going to look in the near future. And then as clinicians, if we change our approach, well, that's one more piece of discomfort that we really have to live with in this piece. And it's easier to break it down to biomechanics. If you spent a lot of time studying biomechanics, which aren't easy, so if you've done that, you're smart, like you've really done a great job. But it's even more complex to think about this as a broad sort of biopsychosocial problem, except that it's really not, because you know what? Our patients are so intuitively aware most of the time around what needs to change in order for them to become less sensitive. And if we get out of the way of our egos, I find most of the time my patients figure this out with a little bit of guidance.
Is it interesting that you bring up that piece there, Carolyn, about most of our clients, including ourselves as clinicians, know where our buckle points are, where we need to change and why. But it's very interesting because the research will tell us that all the knowledge in the world is not the impetus for change. And I had to tell myself that 100 times. And there's times when I still go back and I tell myself that it has nothing to do with how much education you're giving this person. They're only going to change when they are able to attach an emotion and they have some guidance and mentoring and the ability to take those very scary steps forward, because the unknown is more frightening than the known.
Mhm.
And I'll speak from a clinician point of view. It's frightening to leave behind all of these skills and, treatment techniques and algorithms and things that, we've spent a lifetime building up. It's frightening to let that go and to move into something that feels very new and scary. And what if it doesn't work? And so let's blame it on, I don't want to deal with the psychosocial factors. Well, you don't have to deal with the psychosocial factors, but you can be open to empathy and sit with them and listen to them and reflect with them. That's, acknowledging them. But just like I will tell you, any really great psychologist and counselor will say, I'm not going to fix you, but I'm going to help you
Right.
find your way through, right?
I think that's so important, and it comes with that kind of fix-it mentality, and I think that's where some of the discomfort lies with the psychosocial factors. And I've heard people say, well, there's nothing I can do about them. Well, great,
Yes, there
you
is.
don't have to.
Yeah.
But you don't have to. Like, if someone has a history of trauma that they bring up, you don't have to fix that. You can't fix that.
Mhm.
But you also shouldn't deny or
Ignore.
not let people be their full selves.
Mhm.
Like that's so many of us have things in our history. All of it, not so many of us. All of us have things in our history that have
Mhm.
shaped who we are, good, bad, indifferent. And all of that makes us who we are in this moment and shapes our experiences in this moment. And it's just bringing recognition to that. And like you said, Susan, sometimes just acknowledging the suck, acknowledging how hard something is can lift a weight that the person didn't even know that they were carrying. Just that acknowledgement can be huge. And if a person shares something scary that is hard to sit with, it means that they feel safe in that environment, that they feel safe divulging that, and that's a good thing. And you don't have to fix it, and you don't even have to say platitudes in response to it. It can be, thank you for sharing that with me. It's a privilege to hear your story. Those sorts of things can fill those gaps of when you don't know what to say, because we don't always have the right things to say. There's often not the right thing to say, and that's okay. And I think that that's one of the hurdles and the difficulties that we have to get over, especially when you were taught that bodies are machines and you can fix them with these tools. That's a huge leap to make.
If we can look at scope even for a moment, if we look at Timothy Weidman's research, who's a physio researcher at McGill, he has shown that MSK patients in an orthopedic practice, 25 to 50% of them have self-reported depression. So there's a psychosocial distress. What do we know from World Health Organization guidelines? Well, cardiovascular exercise is significant in reducing depression. Yoga is significant in reducing depression. Resistance training, significant in reducing depression. So if we can assess self-reported depression, recognize that as part of the sensitization process of their nervous system, and give them some real solutions to change that sensitivity, we can also give them some hope that their sensitivity can change, right? But it's through a different venue than mobilizing a knee joint or a shoulder joint, or looking at that more biomechanically at this point, right? So it is our scope, but it means that we have to broaden our skill set and broaden our ability to really understand the complexity of pain, and it's complex, right?
And I think too, in terms of that being your scope, like so much of what you do as physiotherapists is trying to encourage people to move more in lifestyle kind of changes that can help to improve their health and in their way of being in the world. And that's behavior change.
Right.
That's like all of that is psychosocial, you know?
Right.
So it's stuff but you've been doing it. It's just not come under that umbrella. So I think that can ease some of the, like I am already doing this. Right. I am already addressing psychosocial factors. I am already doing this in my practice, might alleviate some of those concerns and fears of the unknown and uncertainty of it all.
Excellent. And then the last piece that Holopainen identifies as part of the journey for physiotherapists to move more into a biopsychosocial framework is that it does require a lot of structured learning. It's really a different way of looking at the world, a different viewpoint, a different narrative from our perspective. And that takes time to develop those skills, right? So we need to invest in those skills. And the other key piece is mentorship. You know, it's really interesting that I think as physiotherapists, at least in Canada, maybe the US is different. I know there's a lot more residency programs in the US. Canada, we still don't have any residency programs. But I would say mentorship and support is actually an underutilized and undervalued attribute for physiotherapists. That in the psychosocial world, for sure, if you talk to a social worker or a psychologist, they will tell you that they have a supervisor, that they actually go pay someone once a month to sit down with them, someone more experienced than them, to review some difficult cases, to unload some of the things that they have had to process in the last month. And we don't value that or do that as physiotherapists. And I think as we move into this space, that's going to be a really important component.
Yeah, I agree. I mean, just having, if this is a new thing and it's scary and uncertain, having that support is so valuable and so important. And for the clinician, makes them feel not so alone, which they might if they're in a practice where people aren't adopting this sort of approach, or the people that they're around on a regular basis kind of aren't in line with this way of thinking. Having that mentorship or having a group support kind of network where people can come together and talk about cases and how they're working through them and all of that can be incredibly beneficial. The structured learning part of that paper too really drove home to me, because it talked about how many hours were needed to come to this new way of thinking, that in light of that, the physical therapy education programs really need to be looking at that and start incorporating some of that much earlier on in people's careers, so that they're not trying to gain all of these hours while they're working full-time in practice, to have a more up-to-date kind of understanding of pain and ways of going about treating it. We really need to change what's happening in the schools too.
Yeah, excellent point. So we're thrilled to invite and have invited Dr. Bronwyn Thompson to come and have a discussion with us in a couple of weeks. And so Bronwyn's going to unpack this for us a little bit more and shed some light and some different perspectives. And then what we'll do is on November 5th, we're planning on having an open mic session where all of you can come in and join us through Zoom and ask questions of any one of us, or particularly of Bronwyn, who is going to be our guest expert at this point in this area. And we really hope that you will join us for that session. So thank you from each one of us for listening over this last 45 minutes. I hope that you start to think a little bit more about your interactions with your patients and just giving your space, yourself time and space within your practice to really listen to the narrative of your patients' stories. Until next time.